in a public facility, the IUD stock stood at 66%. And about 8% were either stocked out at the time of the survey or in the previous 3 months. What about implants? Implants, 21% were stocked out in the past 3 months. And in 9%, I'm looking at the extreme bar, and 9% were stocked out at the time of our survey, making it 30%. So implant stockouts were very common compared to the IUDs, which had lower use, as we have seen. But also went ahead and said, what can we look at injectables? Again, public facilities. Part of the reason for public facilities, there are many, and so you can get stable statistics instead of dealing with 1 or 2 facilities. The last column again, 71% in the last survey of 2021, 71% of the facilities were stocked, but 18% were currently out of injectables. And again, whenever I receive a call, Simon, we discuss. We had a case from Nakanyonyi, Sekanyonyi in the Mitiana area, and this is a non-study participant, but through another colleague, got our phone numbers and called and said, well, I've been this place, I've been asked to, I have come for injectables for the past 2 months, but I'm not getting them. What can I do? Poor researchers. We again engage the MOH persons that we have quick access to and tell them the stories, and then they direct us to the potential implementing partners. That's the best we can do, but I think these are real life stories. Interestingly, they are not from our respondents, but they are colleagues or friends of the respondents. So the networking is really working out there. What about oral contraceptive pills stockouts? I dare say nearly half of the facilities we are stocked out either at the time of the survey or in the past 3 months. What are the reasons that are underlying the stockouts? We have been able to make again our inquiries, and we have discovered that a lot of it is supply related. 45%, quite 44.6% of the facilities said they ordered, but they did not receive shipment. And 20%, this is the orange, dark orange, they ordered but not received the right quantities. But again, let us not also miss the 9.6%, which said unexpected increased consumption. Very beautiful. So yes, there's a need to plan and quantify correctly, but for as long as implementing partners, Ministry of Health and others are mobilizing and creating awareness, people are coming and using, and facilities discover don't have enough. But I have also heard there's been redistribution mechanisms. Are they working very well? I think that needs to be discussed and see how well we can address that. And in my kind of winding up, we also looked at, if you are going to provide quality service, the issue of training is one of those things you need to put at the back, beyond the stocks. So for DMPA, or injectable sub-Q, we went ahead and inquired from facilities that are offering DMPA sub-Q, and they asked them whether they offer self-injection training for DMPA sub-Q. Only a quarter, basically 1 in 4, said yes, you're offering the training. You offer the service, DMPA sub-Q, but then the training, you don't seem to be, only 1 in 4 do. And then for those who offer it, the training, we asked whether they have offered in the past 4 weeks. The recency, it is less than half, about 47%. So I think we have opportunity to do better. And personally, I'm not discouraging you. I'm seeing a lot of opportunities and windows being opened for us to now move in on evidence-based. But so also we went ahead and asked about the issues of stock out of specifically DMPA or injectable sub-Q in these facilities, 281, and 64%, nearly 2/3 were stocked, but again about 30% were out of stock of this specific method. Having gone through all this, there could be a lot of summary or take-home message from here. We didn't want to leave this one blank, but also we wanted to provide our thoughts. On one hand, you may have your thoughts, and they'll be extremely important. What do you take from all this data? So one thing is so clear, we are seeing increasing modern contraceptive use. Very important, but also don't forget the traditional is also increasing, and we have found it to be more common among women in wealthier quintiles, the traditional. And of course, DMP or injectables are still dominating, and we have seen about 14% of non-users in the future, they would prefer self-injection. So that is very critical and important. Facilitated desires, you saw 44 or 45%, that white pie chart that Simon shared of women who desire to have children within next 2 years or who are currently pregnant. High fertility temptations. We don't want to say high because we don't know what low is. But is that high? Is it low? Are we doing enough providing what should be provided so that we can create animate need and then address it? Again, that's for discussion. And we also realize that only 1 in 5 women said of non-users they had intention to future use. So we need to go ahead and break into that as well. Are we not providing sufficient information for them to move into the ideation stages, create and give them opportunity so that nobody may be left behind? And for facilities, definitely we are seeing the lack of long-acting reversible implant and IUDs been increasing, especially implant. Reasons for stock out has been shown, and we kind of have a sense of why the stock out issues are because of delivery issues. Again, we need to again discuss that, and I understand the loss of dynamics going on and to try and address that issue. And of course, the quality of services as indicated through the information index low. Only 43% have all the 4 side effects being told, didn't know what to do, other options. Only 4 out of 10 actually have that information. So given that, I think this can help us form a nice discussion. I know we don't have sufficient time. We can continue engaging through all these channels. But also it's okay, I think, to organize small meetings. We are usually part of the technical working group for family planning, but also we can engage other partners, different fora, to discuss this, because we have done that, and it has been very helpful because it has informed their programming subsequently. We don't want to leave it here, but I think every one of us has an opportunity to play their role. We generate evidence, we work with the Ministry of Health, implementing partners, population council, and everybody. So every one of us, the policy people, the program people, the data generators, so that we can have evidence-informed decisions, and I can bet you me that can make a significant difference. And I'm glad to see our members of parliament who can help and support when all this information gets to parliament, and say we need more funding if that's what we need. So thank you very much for listening, and I guess you can step into the next chair. Over to you.
Another big round of applause for our presenters. They've done a great job. I received a request by our honorable members of parliament. They're excusing themselves to go for another important meeting, an update about the Public Health Act. So we would maybe remain with a few of them, but some of them have left. Let's now have a presentation from Dr. Betty, and that marks the end of the presentations, and then we discuss at once. This is a meeting that's supposed to end at 10:30, and I'll end it at exactly that. Dr. Betty, you're welcome. Join me in welcoming her, and she will spare us some minutes.
Thank you very much, Chair, Dr. Mugahi. The honorable members of parliament who are still with us, the chair of the technical advisory group, who is my boss, Dr. Jotham Musinguzi, colleagues, ladies and gentlemen. I was requested to make a summary of a presentation, but I'm not going to make a summary because I'm sure all the people in the room are able to listen in and pick issues as they have been presented. Actually, on my table, the team that is sitting there was very excited about the results that have been presented today. So I'm going to make a more contextual inroad into what has been presented and what are we supposed to do as the different people sitting around the table. What will be our role in ensuring that the evidence that has been presented to us today is put to action. So number one, there is no doubt we're seeing an increasing uptake of family planning services. Both modern contraceptive prevalence rates and the total modern contraceptive prevalence rate have been shown to be increasing. And I think we need to give ourselves a big hand clap for such a huge achievement as a country. But nonetheless, there's more need to transform this potential family planning use into what we want to see. Yes, we are seeing increasing uptake of family planning services, but what do we want to see the increasing use of family planning services for? Are we seeing it making a contribution to reducing fertility? That is question one. If we are to receive results, for example, of a demographic and health survey Mr. Mwonge has worked out, what is our fertility rate going to be as Uganda? Are we going to see more reduced child mortality? Are we going to see improvement in the health of mothers in terms of reducing maternal mortality ratio? Are we going to see an increase in terms of the investments that we are making in improving and transforming the socioeconomic aspects of our country? So these are the questions that we need to speak about. But even as we see the increase in family planning services, is it showing us an increase in the support for the people who want the family planning services to receive the service? So are we seeing, we have had representation of our members of parliament, and for those that have engaged and consistently work with them, they are committed to the family planning agenda of this country. But how committed are the leaders in the districts, in the local governments? We now have cities, we have municipalities. What is the level of commitment? And I think next time, Professor, we need to invite districts, or are they here, so that they tell us what is happening. Because with the development of our first family planning costed implementation plan, we agreed that we are going to domesticate the national FPCIP at districts. Dr. Mugahi must be smiling because he keeps asking us, what have we done as the National Population Council to make sure that all districts or all local governments have their family planning costed implementation plans? So ladies and gentlemen, I think these are some of the questions that come out of this presentation. So even as we think about generating data and using data for informed decisions, are we seeing data that is coming from the HMIS, from the DHIS2, being used to inform decisions about the planning aspects within the districts? To what extent are we integrating, for example, the issues of DMPS sub-Q in HMIS? And I think this has been a question that is grappling Dr. Olaro. Even when we have the meetings on DMPS sub-Q, we are still grappling with ensuring that DMPS sub-Q self-care, self-injection is integrated in the HMIS. But we are also looking at how are we going to convince and work with pharmacies to integrate DMPS sub-Q at pharmacy level. Because we know that it is easier for me to go to a drug shop or a pharmacy and pick any type of commodity, whether it is for treatment of malaria or whether it is for family planning. It is easier to do that than to go to a health facility. So that is the other question that we pick from this presentation. Then in terms of there are issues that have been pointed out, which we must focus on. The use of contraceptives by certain groups such as adolescents and men. These have been largely overlooked, and in this presentation we have seen use by young people, even when it comes to what they call the counseling, the information, I haven't yet picked that language very fast, but you all heard what it is. In terms of counseling, it is the adolescents that don't get adequate counseling when they need the services. But we are seeing an increasing number of teenage pregnancy rates. And if we are not going to work with these young people, I'm sure Dr. Msingus is going to come and give us a presentation on our development perspectives as a country and why we must focus on improving family planning use among adolescents. I think it is high time we really focused on ensuring that our adolescents who are sexually active access and use family planning services. Then the other issue that has come out is about the distribution of contraceptives beyond the health facilities. We know, and I have alluded to this already, where are our family planning service delivery points? We know and we appreciate the role that different implementing partners play in improving family planning services by ensuring that we have outreaches, we have services received and distributed at different levels. But I think we need to do more and work more with the community health workers and VHTs, especially if we are going to increase family planning services. But even as we do that, remember this meeting is about evidence generation. Are we going to be smart enough to ensure that what the services that are provided outside the traditional service delivery points, the health facilities, we have that data integrated within the HMIS, because I think we usually have gaps at that level. So the other point that comes out for me is on expansion of types of contraceptives, including the sterilization. The chair has told us or we were informed that he's a champion of vasectomy. I knew one champion of vasectomy. This morning I have learnt a number of vasectomy champions. And this is very great news, I think, for us. If we have more of these champions and they convince more of the men in communities about the benefits of family planning, I think we shall have done a great job for this country. So increasing and expanding the types of contraceptives is very, very vital for us. But also the role of a private sector, including the commercial sector, to provide services and facilitate local and private initiatives. And also the collaborations with the private sector are very key in improving efficiency. So we cannot overlook the private sector in terms of expanding our family planning program. And also the family planning program effectiveness hinges on large-scale efforts that can be sustained over a long period of time with strong leadership and commitment in terms of finances and technical support. I have already talked about the commitment that we are receiving at national level, but are the finances enough? And we have also seen some of our challenges are, one, in this presentation, we have seen last mile delivery. Because yes, commodities, we have better stocks at the facilities now, but some of the reasons why there are stocks, it is because what we requested for, what we ordered, is not what was sent, or what we ordered has not yet been delivered. So we still have challenges with the last mile delivery. And I fear, looking at my boss, National Medical Stores, I think still has a little more work to do in this particular area, but with support of all of us. So, but also within the local governments, how have we prioritized family planning? The partners that have supported the development of district family planning costed implementation plans usually start by constituting a group of leaders, multi-sectoral working group, to bring forth the discussion on family planning, even before they finalize the district family planning costed implementation plans. But after the plan has been developed, what happens? Is it financially supported? Is there room for coordination? Is there room for ensuring accountability? So if we can do some of these things right, ladies and gentlemen, I think we are soon going to see the MCPR even beyond what we have put as our target. And as I conclude, I also just want to make a few points in relation to the programs that we already have in terms of improving family planning. One, the third National Development Plan has given us 2 major programs that will help us improve family planning service delivery and family planning, the agenda for this country. One, the Human Capital Development Program. So when we are presenting and disseminating some of these findings, we need to invite the Human Capital Development Program partners to this meeting. Ministry of Health is very well represented. Is Ministry of Education and Sports in the meeting? Is Ministry of Gender, Labor and Social Development here? Is Ministry of Local Government here? Because we continuously speak to ourselves, and yet we know we have a challenge of making sure that family planning should be implemented in a multi-sectoral approach. Then we also have a community mobilization and mindset program, which is very key because we continue seeing myths and misconceptions. When the media reports on family planning, we usually pick the negative aspects about the family planning program. We don't mainly see the benefits. So there is room for us to continue engaging with some of these programs. And lastly, we also have a parish development model. I'm not yet an expert, and I don't have so much to speak about the parish development model for improving family planning. But I usually want to hear voices of representatives from the local governments, how they feel this is going to help us. Because 2 of the pillars of this parish development model, 1 is increasing service delivery, but also 2, ensuring that we have a mindset change. And we have negative perceptions about family planning. And I think it is high time that we engage strongly to change the mindset on family planning, but also improve family planning through ensuring the service is delivered. Lastly, ladies and gentlemen, in the presentation, issues about promoting technology came out strongly. And I think we cannot run away from integrating technology into our family planning agenda. So with this, ladies and gentlemen, allow me hand back to the chairperson, and thank you so much for listening to me.
Thank you so much. Thank you, Dr. Betty Chadondo, and for opening the platform. Now it's time for our discussions, and I'll be supported by Ms. Harriet Adong. First of all, we have an online audience, and I think Melody, will you help us summarize the online comments? Because of the time we have here, I would encourage the online participants. I'll pick some few hands there, but I would encourage our online participants to put their questions on the chat group, and we pick them up. We should be able to appropriate them to the respective speakers. And then from the house, how do we find out if they are online hands?
So we have some comments,
okay.
Chair.
No hands, okay.
Yeah, and we have some questions online. Maybe we start off with online.
I could invite the presenters to step forward. Simon and you're comfortable there? Academicians, they hate high table. You come. Professors fear high table, I don't know why. No, it's part of recognition for the great work you did.
So Chair, how do we do this? We go with the online, a few questions
yes,
online,
please,
and
please
then
do.
we'll come back to the physical audience. Okay, so online, we have quite a lot of questions. So I'll just read through the first 6, and then maybe we give a chance to our principal investigators to respond. Question 1, thanks for the data. Regarding the quality of services, I do appreciate the gap in health education, stroke family planning counseling. But how have you accounted for recall bias from the respondents? Number 2, 40% of current users are not told about family planning side effects. Does this differ from family planning methods? Are some women more likely not to be told about side effects than others? Finally, this presents a missed opportunity to inform women about side effects so they can make informed decisions. Question: what strategies are in place to reduce the proportion of women who are not told about side effects? The other question, if I'm first, please signal to me. If the SDPs where the respondents accessed the contraceptive methods are disaggregated by facility versus community distribution mechanisms, will the findings about the quality of counseling be different? If the SDPs where the respondents accessed the contraceptive methods are disaggregated by facility versus community distribution mechanisms, will the findings about the quality of counseling be different? Should I give you another? Okay. The other question is, it would be great to break down this data by regions. Is this possible? The other is, what percentage of women using DMPA-SC were adolescents? That is 15 to 19 years of age. The other, what channels of information on DMPA-SC were most effective? I guess you will stop me. And then the other question is, how did self-injection use differ across age groups? Okay. The other is, we are still having family planning commodity stockouts in 2022. What is the interim plan to fast track this gap before we lose our gains? Okay. Then the other is, 79% of non-users did not intend to use contraception in the next 12 months. What implications do these findings have on demand creation for contraception among potential users? I think I can do the 3 more and then hand over to you. It is ironic that despite COVID-19 and the restrictions put in place, the data is much more encouraging than expected. Please disaggregate adolescent-related data, especially in rural urban areas. And then the second last for now is, provide the percentage of facilities offering family planning services vis-a-vis the non-providers disaggregated by region. Facilities offering family planning vis-a-vis the non-providers, and this should be disaggregated by region. And then the last for this round is, what accounts for poor uptake in institutions, even below primary and secondary school youth. What is the age profile of this cohort? Chair, I hand over to the principal investigators. Thank you.
Thank you so much. I think there have been a couple of questions really, and some are really to the presenters, others are to the programmers in the house. Yeah. But I would like our presenters to focus on what really belongs to them. Then the rest we shall attempt to also respond. Thank you. Yeah, that could be fine. And some of them actually might be. I think that's good guidance from Dr. Charles. We get also the questions from, okay. And also feel free to write down your question. Feel free. We may not have enough time for everyone to ask their questions, but feel free to write your question and forward it to the front desk here. Thank you, Dr. Charles.
I want to thank the principal and the co-investigators. I did observe when we did disaggregated by education that there was a drop at tertiary. I was trying to wonder, I thought as education improves, goes up, actually uptake also goes up. So I was just trying to understand what was the challenge in that. Probably we might need to understand what's the challenge in that strata. The other aspect which I wanted to make, it might not necessarily be a question, it was an aspect of observation, is that currently we don't have a product for the private sector for the self-injection. And I'm sure if we had, then it would drive. So I think this is where we need to work on and be able to see that we introduce a product for the private sector, and then you will probably be able to see how self-injection will skyrocket. Those are my two comments.
Yeah, thank you, Chair, and thank you, the presenters. Mine is the issue of the use of IUDs. How can we improve? Because there is an issue where women fear side effects. When you get some information from women, when they are discussing in the saloons and what, when you talk among them, when they talk among themselves, they say, how can I put it? I'm not sure about the behavior of my husband. That's sometimes the reason they give. Fear of STIs. Sorry.
Thank you very much to the presenters. I really thank you for this eye-opening presentation. Mine are two comments. One, on behalf of my neighbor who's leaving, a thank you to the 1.1% of men who help to inject their partner. Yeah. I think that is really, really commendable. And if we keep encouraging these people, I think it's really a great way to involve the men in the women's health. Now, I want to comment on the social determinants of health, and I'm linking this to what we saw in the presentation and what Dr. Mihayo is talking about, the low uptake of IUDs. Last week I was in Rakai, and I had informal discussions with a group of women who had come to get their family planning method. And they all seemed to know what they wanted. They knew, I want an injection, I want this. So I just engaged them and asked them why. Why do you want this and not that? Do you know about the others? And out of 6 women I spoke to, 4 of them told me they had used an IUD. They had a bad infection. The IUD was removed. And of the 4, 3 said they would never use it again. So I thought of, what else beyond health? I thought of water and environment, sanitation, I thought of education. All these things were running in my mind. And those now are missed opportunities. So linking that to the discussion we are having here, I'm so happy that Dr. Betty talked about the human capital development program, because it gives us an opportunity to bring the different sectors on the table, and it is something we as stakeholders need to adapt to, take it forward, involve other sectors, speak with them, let them give us their ideas, and that way we'll come up with some solutions that are outside of the norm that we've been practicing over time. Thank you.
Thank you, Dr. Rita. We shall take 5 questions, and as I mentioned, we are going to encourage the rest of us to write down our comments. Yes, take that question, please. Harriet, it's okay.
Thank you so much, Fiona Lugembe from Perth. Thank you so much for the presentation. Dr. Laro talked about the private sector commodity for DMPSC. I'm just giving information that around 2024, we are likely to have this product. This is work in progress. But also to emphasize the issue of quality counseling as a recommendation, in addition to Dr. Betty's comments, and also demand creation. And in this case, not just talk about it, but for instance, the Ministry of Health, how can we track who is doing quality counseling? Because we've talked about this over and over. For instance, we know that now we are doing the ready, but you'll find other people still doing the gather. So I know you've talked so much about it, but what more can we do? Thank you so much.
Anyone here?
And we'd like to stop at that now and probably provide the answers. I don't know if they're the answers, but
Thank you, Professor Frederick and Simon and all the other speakers who spoke earlier. Mine is to do with the Method Information Index, and in particular the issue of the side effects, but speaking about the issue of return to fertility as a key issue. It seems that it is a key issue, but it's coming out in this study, but also in another DMPSC study that I've personally been an investigator for. And it doesn't seem to be as such a side effect. It's more of a misconception, but also an entrenched norm that fertility return to it is a very important issue to women. And so sometimes they delay the next method, and within that window, they get pregnant, even with the most popular method, the injectables. So probably it needs some further study, some further understanding and intervention. Thank you.
Honorable Lydia Makerere, the midwife and APA course is done family planning for some time.
Thank you very much, Chair, and all members present and on vacuum. I want to comment on Dr. Betty's presentation, where she said that if the uptake is really to improve, we have to use the grassroots health workers. That is the VHTs plus other grassroots health workers in those very sub-counties and villages and the parishes. This practically improves family planning uptake, because I can take an example. When FHI was having the program of community family planning using VHTs, thanks to FHI, Frederick and Chris. By that time I was in Kamwenge, and that program empirically increased family planning services in the district. And the system was very clear in that the information could be captured and taken into the database of the district. We would not lose any data. So I would think that it is a very good practice for all partners who are in this room. VHTs are very important people, and they are very committed to their work. They can even be more committed than trained health workers, by the way, when you train them, and they know what they are doing. So if we are to improve on the family planning services, more partners should think along that lane. Then something on parish development model, how it is likely to impact on family planning uptake. You see, when you are trying to move the agenda of family planning in communities out there, most women are worried about, they are worried on their income levels. And they are like, when we are doing hard work and we are using some family planning methods, we get a lot of side effects. We get dizziness, we get excessive bleeding. Of course, most of them are what? Are myths. But like we said, parish development model is going to work on mindset. First of all, when these people are having their meetings on how to use these funds at parish level, so health workers can always be there. First of all, most of the partners that are providing family planning and the government itself had not worked on the other social determinants of health, like livelihoods. But now that this money is going to come to parish level, health workers can always integrate in their services, as they are also telling them to do what? To utilize family planning, now that they even have something to improve on their sources of income. And their mindset will change, and also the uptake will go up. I thank you.
I now invite my presenters to respond to some of the questions, and MOF will also respond to some. Thank you so much for those questions. Professor.
Okay, sure. So thank you very much for all the questions and comments and suggestions. Some of the questions actually are for all of us, meant to help us dig into the data a little bit more. We never prepared it that way. Thank you very much, Dr. Laro. The education component of the tertiary education, the numbers are small and noisy, but also we've been grappling with the way of making sure who is a tertiary in our data. Because if somebody finishes S4, goes and does a course, technically speaking, we call them tertiary, which is understood to be post, maybe even secondary. Yeah, so we are trying to refine tuning our tools so that we can better understand them. But also we are messed up with the numbers. That's why you saw those what we call error bars very tall. But we shall certainly work on that a little more. Then the other thing quickly, somebody asked about a question from the internet about the recall biases of the method information index. Yes, surveys always have recall biases, but on the other hand, you keep asking yourself, why do you believe this indicator and not the other indicator? And but out of that, also on the other hand, you go ahead and step and say we've taken precautions in terms of training, but also most importantly, we have recently included the client exit interviews, which may help us possibly capture more recent, basically hours, recent information about this. But that's the dilemma we face usually in most of the surveys. The best thing to do, train, supervise. We, Dr. B talked about this, and for the sake of everybody else, we have been working with Ministry of Health, National Population Council, and a number of partners conducting what we call regional disseminations. We've been able to go to about 5 regions, and with implementing partners. Dr. Mihai, I know we used to travel with him, and many others. Dr. Mugai, we are with you recently, Dr. Bechadon and the rest, and we want to continue doing that because we want to go. This has been national level. The DHOs are not here, and many partners aren't here, but we usually go with the partners working in that region and say, this the results, can we discuss and hear what's going on here? Of course, the statistics, we shall break them down, but the challenge again is that we don't have usually sufficient numbers when it go lower. But again, you're able to live within the available information and share it with, and we shall continue doing that. I hope partners are going to be fully available so that we can go together. I don't know if COVID, things have been improving. This goes back a pilot, what again was said. I have been able to be part of the team looking at the HMIS data. The most greatest effect of COVID was in 2020 in the month of April, thanks to government, Ministry of Health, and many key players, by June, a lot of things had improved, really, because of the strategy that we are put in place. And I think somebody made a comment, can we not continue look at those, how well they work, and maybe enhance them more? Maybe the result of what we are seeing. Yes, so I think we need to make sure we enhance what we did previously. I have decided to leave the harder ones to my colleague, Simon, to address them. But Dr. Rita, I was impressed with the 1.1 also, whereby men supported their partners in injecting. So this injection thing, don't leave men behind, even as we promote for those employment partners who are involved in this. Thank you very much. I hope I've been able to reasonably address some of the issues and concerns.
Thank you so much, Professor. He has summarized all the things. And I just wanted to add that this is not going to be the end. It's the beginning of the discussion, the synthesis. The professors have provided us from JMS, Alternative Distribution System. Together with Dr. Muonge, who has moved out, we are promoting the self-injection. Dr. Laro, in line with your comment, we've not reached up to scale, but we are moving steadily. Most of the documentation and paperwork has been done. The pilot programs are doing well, and we intend to scale it up. I think this might be a magic bullet because we are seeing very high uptake of injectables. We are also seeing private sector doing a good job in terms of access. So this has the ingredients of being a magic bullet. Stockouts for some key commodities, this happened at some point last year. We are aware, and I think Betty has pushed it, Dr. Musinguzi, but I also have his hotline. I can engage him remotely, especially some of the key stocks that we really need at facilities, the injectables. The redistribution mechanism is one of our biggest asset in addressing stockouts, pseudo stockouts. And it has been working quite well in some districts, and we expect it to work better now that we have at least pickups, 2 pickups in every district. We expect it to work better. We only need to intensify that they need to do it very well. The COVID pickup, some people were criticizing. They're going to help here. Lastly, the quality of counseling. Quality of counseling is an issue, and I think we are going, I can't promise an answer. It has been recurrent. It is acute on chronic. It keeps coming up. So I have no automatic answer here, but I want to assure you that we are looking at it very closely. We have the National Family Planning Think Tank that digests some of these issues and look at them critically and what implementation lessons we learn from them. I had forgotten, we are introducing or we are already doing something called pharmacovigilance, specifically for FP. We are trying to pick on some of these side effects. The Department of Pharmacy at the Ministry of Health is leading in the pharmacovigilance for reproductive health commodities. So the issue of side effects is our area of concern and how its impact on utilization. So those were the comments that were directed to the Ministry of Health. We can always have more engagement about the same. And we think my colleagues here, the presenters, have also done a good job. A big round of applause to those who asked and those who responded. And allow me at this time move to the last item on the agenda. We are only slightly out of our time, and the last item on the agenda is inviting our very important guest who has been with us from the start. Someone you all know who has been well introduced. He is the chair of the PMA. You want to introduce? He is the chair of the PMA National Advisory Committee. Yeah, feel free. Feel free. He is also the chair of the board of the National Medical Stores. Of course, he sits on a number of international boards. He is a seasoned healthcare practitioner. He has been a lecturer to most of us. He's still lecturing us. And he has been a champion of the family planning programming, the population dynamics in this country. I cannot describe him enough, but join me in welcoming him to make...
Richard Mugahi, who has also been chair of this session. I think I have liberated my face by removing the mask. The honorable members of parliament still present. I think I recognize one, but there could be others. The Dean of the School of Public Health, Professor Rhoda Wanyenza, I hope you are still with us virtually. Dr. Charles Sorara, who is the Director for Clinical Services, Minister of Health. The leadership of PMA, Professor Fred and your colleague Simon and others here present. The leadership of UBOS, partners in the field, religious leaders, the media, ladies and gentlemen, and those who are attending virtually. I know we are past our time for this, but I thought that what I really do is to thank all of you for being here all this time. We had a good contingent of members of parliament led by the chairperson of the Committee of Health in the parliament and a number of others, and we want, when Honorable Sylvia, you go back to give them our thanks for supporting this process of the PMA. But I also asked that Dr. Charles Oraro stays on because I have an important message which I wanted to deliver. That this morning I have seen that we are concentrating on family planning, but very little benefits of development are coming out. And I wanted us, since Parliament is here, but also the Minister of Health were represented with several implementing partners and development partners as well, to know that family planning is also a development issue. And I think Betty touched on this. I know she gave me instructions to, Betty dares to give me instructions what to say and what to say. But I also know that she wanted to speak about the demographic dividend concept. And she put it in a good way by talking about the parish development model. As you know, the Uganda is moving into this. We have a great opportunity, and I think I heard Rita and also the Honorable Sylvia talking about this, that we need to go down to the local level and engage our communities so that we can start making a difference. Family planning and reproductive health, Dr. Mugahi, Richard Mugahi, you know very well, you have worked the districts. This is a conveyor belt for making sure we deliver development for this country. I don't see they have removed my good slide. I wanted to, most of you know it, but I want to take advantage of the several members of parliament here present. 3 weeks ago, I took a team of National Population Council to appear before the Budget Committee, the Finance Committee of Parliament, and we are able to talk to members of Parliament, show them the need for them to continue investing in the population and enrollment field, in reducing fertility of this country, both looking at issues that the Ministry of Health itself can be able to do, but also linking it with education, because education is also very important in reduction of fertility. So these are sectors, can it go on the screen? I don't need it myself, but it needs to go there. The idea is to really link these sectors in the context of the parish development model, which are going to impact on reduction of fertility and reducing it fairly rapidly so that the country can benefit from a demographic dividend. The demographic dividend is when you reduce fertility fast enough, not business as usual. If we do business as usual, Uganda will never be able to benefit from a demographic dividend. But we have an opportunity now that Fred and Simon have shown us that we can impact on contraceptive prevalence, we can push it fast. We need to make sure that education, health are working together so that the country moves from a pyramid that is very heavy at the bottom to a sort of pyramid, not exactly a pyramid, but there's a lot of people in the middle, and if these people get education, they get health, they have skills, then you have a huge population which can be the engine of growth, and I think of economic growth. And I think this is what we are talking about. Since about 10 years ago, 2012, 2013, Uganda has started witnessing the demographic transition process. Both fertility and mortality are coming down together. That is when a country enters the window of opportunity. And so I wanted to say that this is an important thing, and we need to continue linking reproductive health and family planning, and especially use of contraception, and making sure that our CPR goes up. And working with the Ministry of Health, working with the Ministry of Education and others, that is the way that we are going to make sure we do big impact on the education, on the health, and eventually the country exploiting its demographic dividend. With that, I think a lot of things have been talked about. Once again, I want to thank you for your participation and your keen interest. I think the country is at a point where if we continue to do things right, there is an opportunity that, as you can see from the family planning, there is some good things, some good news there. Challenges remain, but I think we're on the right track. And with that, it is my pleasure to officially declare this PMA dissemination, national dissemination and dialogue officially closed. Thank you all.
Okay, thank you so much. That brings us to a close. We would love to have a few group photos here with our principal investigators, our chair, just at the front here. Once again, thank you so much, all of you, for being a part of this. A big thank you to our online audience. Thank you for keeping with us up to now. Sorry. Honorable, come and join in the group picture. Yeah, we need some gender within this photo. Family planning is dominated by gentlemen, which is a good thing. Okay, so we are set for the group photo. Meantime, we are still thanking all our online audience. Thank you for being a part of this. Okay. Keep smiling through the mask. And once again, congratulations to the PMA team. We look forward to putting these results into use. I think we are good with the family, with the group photo. Yeah, we keep the discussion on family planning ongoing. For our online audience, we promise to respond to all the questions. And thank you for all the comments. I think Golden Tulip still has our tea, so feel free to pick a cup of tea as we continue with the dialogue. We still have over 70 participants online, and we want to thank them for keeping with us. So we want to request, we have a request. Davidson. Okay. 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 We have an announcement. Dr. Chibira, we have an announcement. Our media fraternity would love to engage with you specifically. There is a seat over there for you. So the rest of us, we will speak with very low tone of voices. Ladies and gentlemen, we need to reduce our voices so that, and so that we can have some media interviews. The media would like to get this message very clear. Dr. Mugahi, you are also